There's something your cardiologist probably hasn't told you. Not because they're hiding it, but because most of them were never taught it. I'm Dr. Elliot Hargrove, and for the past 22 years, I've worked as a vascular surgeon. I've operated on hearts, on aortas, on coronary vessels so damaged they barely resembled living tissue anymore. I've held arteries in my gloved hands and seen, with my own eyes, what years of uncontrolled blood pressure actually do to the human body. And what I've seen has changed the way I think about hypertension entirely. Because what I was taught in medical school, what most physicians still believe and still teach their patients, is dangerously incomplete. We were told that high blood pressure is essentially a plumbing issue. Too much fluid in the system, too much salt in the diet. Reduce the volume, lower the pressure, problem solved. Give the patient a diuretic, maybe an ACE inhibitor, check the numbers at the next appointment, and move on. That explanation is not just outdated. It is, in every meaningful clinical sense, wrong. High blood pressure is not a fluid problem. It is a structural problem. It is a disease of the vessel wall itself, a disease of rigidity, of calcification, of microscopic damage that accumulates silently over years and decades while the blood pressure numbers sit there, controlled by medication, giving everyone a false sense of progress. I have opened chests and found arteries so stiff I could barely thread a surgical needle through them. I have seen vessels that looked less like living tissue and more like sections of old pipe, calcified, inflamed, rigid. And every single one of those patients had been on blood pressure medication for years. Their numbers were fine. Their arteries were not. So let me tell you what hypertension actually is, and more importantly, what you can actually do to reverse it. Your arteries are not passive tubes. They are living, dynamic structures built in layers, each one serving a specific biological function. The innermost layer, the one your blood touches every second of every day, is called the endothelium. It's a single layer of cells so thin it's almost invisible to the naked eye, and yet it functions as one of the most important organs in your entire body. It regulates blood flow, prevents clotting, controls inflammation, and produces a gas called nitric oxide that keeps your vessels relaxed and open. But here's something even most cardiologists don't fully appreciate. Coating the inside of that endothelial layer is a structure called the glycocalyx. Think of it as a microscopic protective lining, a biological layer of sugar molecules and proteins that acts almost like a non-stick coating on the interior surface of your blood vessels. It creates a frictionless environment for blood to flow through. It shields the vessel wall from inflammatory damage, and it acts as a sensor, detecting blood flow and triggering the production of nitric oxide in response. When this lining is healthy, your arteries function beautifully. When it's damaged, everything unravels. What damages it? Elevated blood sugar, even temporarily, even if you never qualify for a diabetes diagnosis. Chronic inflammation, cigarette smoke, oxidative stress from processed food, environmental toxins, and ongoing psychological strain. These factors attack the glycocalyx the way acid attacks a protective coating. Once it's compromised, inflammatory molecules that would normally be blocked gain access to the vessel wall. White blood cells begin to adhere. LDL cholesterol penetrates the lining. Plaque formation begins, and the endothelial cells, now exposed and stressed, stop producing adequate amounts of nitric oxide. The vessels lose their ability to relax. They constrict. They stiffen. Blood pressure climbs. This is the first mechanism of hypertension, and no blood pressure medication in the world repairs it. Dr. Hargrove treated a patient I'll call Arthur, 69 years old, on 3 different antihypertensive medications for the better part of a decade. His blood pressure readings were consistently acceptable. His doctor was satisfied. Arthur felt fine. Then one morning he experienced a mild but unmistakable cardiac event, and he ended up on my operating table. When I opened his chest and examined his coronary vessels, they were rigid and heavily calcified. Sewing a bypass graft to one of them was like working with concrete. His medications had controlled his numbers perfectly. His arteries had been quietly deteriorating the entire time. Arthur survived, but the point is that he should never have reached that operating table. The medication was managing a symptom while the underlying disease was progressing unchecked. That is the nature of the problem. The second mechanism is something called arterial stiffness, and it's the one that reveals more about cardiovascular risk than almost any number your doctor currently tracks. When doctors measure blood pressure, they get two values: the upper number, which reflects the pressure during each heartbeat, and the lower number, which reflects the pressure between beats. The difference between those two numbers is something called pulse pressure. In a healthy person with flexible, elastic arteries, that difference typically falls between 40 and 50 points. But as arteries stiffen with age, inflammation, and calcification, the upper number rises while the lower number actually drops. The gap widens. A pulse pressure above 60 is a reliable indicator of significant arterial stiffness, and it predicts stroke and cardiac events more accurately than either number alone. In a healthy aorta, the vessel expands slightly with each heartbeat to absorb pressure, then recoils to push blood forward during the rest phase. It's an elegant shock-absorbing system. In a stiff, calcified aorta, that system fails. The pressure from each heartbeat slams directly into the vessel without buffering. The upper number spikes. The lower number falls. The pulse pressure widens, and the cardiovascular risk climbs steeply. There's a test called pulse wave velocity that measures exactly how stiff your arteries are. It takes about 10 minutes and is completely non-invasive. A result below 7 meters per second indicates healthy flexibility. Above 12 indicates significant stiffness and high risk. Most physicians never order this test, not because it lacks value. It's actually one of the most predictive measurements in cardiovascular medicine, but because there is no pharmaceutical solution for arterial stiffness. If a doctor finds it, there's nothing in the prescription pad to address it, so the test doesn't get ordered. The stiffness goes unmeasured and unaddressed. But here's what matters. Arterial stiffness is reversible, not with medication, but with targeted biological interventions that work at the structural level of the vessel wall. The calcification that causes stiffness doesn't happen randomly. It's regulated by proteins, and the most critical one is a molecule called matrix GLA protein, MGP for short. This protein acts as a regulatory signal for calcium. When it's activated, it directs calcium to your bones where it belongs. When it's inactive or insufficient, calcium migrates into the walls of your arteries, forming crystals that progressively harden the vessel. The molecule that activates MGP is vitamin K2, specifically a form called -7-malonyl-CoA:s. Without adequate K2, MGP remains dormant. Calcium deposits in the arterial wall unchecked. With sufficient K2, MGP becomes active and begins redirecting calcium out of the vessels and back into the skeletal system. Studies in both animals and humans have demonstrated that this process can actually reverse existing arterial calcification, not just slow it, but genuinely reduce it. Working alongside K2 is vitamin D, which governs how much calcium gets absorbed from the gut and how efficiently it gets incorporated into bone. And then there's magnesium, perhaps the most underappreciated mineral in cardiovascular medicine. Magnesium functions as a natural calcium blocker inside the smooth muscle cells of the arterial wall. When magnesium is present in adequate amounts, it prevents calcium from flooding those cells, keeps them relaxed, and inhibits the formation of calcium crystals in the vessel tissue. When magnesium is low, and in the modern diet, it almost always is, calcium accumulates freely, arteries stiffen, and blood pressure rises. Dr. Hargrove worked with a patient I'll call Eleanor, 73 years old, 20 years of hypertension from medications, a CT scan showing advanced aortic calcification. Over the following 18 months, she was placed on a protocol built around vitamin K2 at 360 micrograms daily, therapeutic dose vitamin D, and highly absorbable magnesium glycinate at 600 milligrams daily, alongside meaningful dietary adjustments. At 6 months, her calcium score had decreased by 8%. At 18 months, it had decreased by 15%. Her blood pressure normalized enough to reduce her medications from 4 to 1. Her arteries were structurally remodeling. The calcification was retreating. That is not a minor finding. Arterial calcification is supposed to be progressive and permanent. When it reverses, something real has changed. The third mechanism involves nitric oxide, or more precisely, the loss of it. Nitric oxide is produced by the endothelial cells, and it signals the smooth muscle in the vessel wall to relax. It is your body's primary natural blood pressure regulator. A healthy endothelium produces it continuously. A damaged endothelium, one stripped of its protective glycocalyx coating, produces far less. The vessels stay constricted. Pressure stays elevated. The enzyme responsible for producing nitric oxide depends on a cofactor called tetrahydrobiopterin, or BH4. When oxidative stress is high, BH4 gets depleted. The enzyme becomes dysfunctional and begins producing free radicals instead of nitric oxide, making the vascular damage worse rather than better. Restoring antioxidant capacity through polyphenol-rich foods, leafy vegetables, berries, dark cacao, green tea, protects BH4 and allows the enzyme to function properly again. But there's a specific physical intervention that restores nitric oxide production in a way almost nothing else can match. Isometric hand grip training. The protocol involves squeezing a resistance device at 30% of maximum force for 2 minutes, resting briefly, and repeating 4 times. Clinical studies have demonstrated consistent blood pressure reductions of 10 to 15 points systolic after 8 weeks of this practice alone. The mechanism is mechanical. The sustained contraction briefly compresses the vessels in the forearm, and the subsequent release creates a surge of blood flow that exerts shear stress on the endothelium. That shear stress activates the nitric oxide enzyme. With repeated sessions, the enzyme becomes more responsive. Baseline nitric oxide production rises. Resting blood pressure falls. Nasal breathing also plays a meaningful role. The nasal passages produce nitric oxide continuously, and when you breathe through your nose rather than your mouth, that nitric oxide travels into the lungs with each breath and enters the circulation. Studies have shown that nasal breathing can increase blood nitric oxide levels dramatically compared to mouth breathing. A simple, costless intervention with measurable cardiovascular effects. Dr. Hargrove treated a patient I'll call Samuel, 65, hypertensive for a decade, on 3 medications. He implemented the nitric oxide protocol, dietary optimization with folate, vitamin C, and E-rich foods, isometric hand grip training 4 times weekly, and a deliberate shift to nasal breathing during his daily walks. Within 2 months, his blood pressure had dropped enough to remove 1 medication. Within 6 months, he was down to 1. His endothelium had recovered its ability to regulate its own pressure. The fourth and final mechanism is the one most physicians miss entirely, and arguably the one that explains the most cases of treatment-resistant hypertension. It involves insulin and the way chronically elevated insulin levels lock the kidneys into a state of perpetual sodium retention. Your kidneys regulate blood pressure by controlling how much sodium stays in the body. Eat more salt than you need, and healthy kidneys excrete the excess. Eat less, and they conserve it. This system keeps blood volume stable and blood pressure in range. But the system depends on one crucial variable. Insulin levels must be normal. Insulin tells the kidneys to hold onto sodium. This was biologically useful for our ancestors, who needed to conserve every resource during periods of food scarcity. But in a world where most people eat multiple carbohydrate-heavy meals throughout the day, insulin levels are chronically elevated. The kidneys are permanently locked in retention mode. It doesn't matter how little salt a person consumes. If insulin is high, the kidneys will recycle virtually every milligram of sodium in the body. Blood volume stays elevated. Blood pressure stays high. This is why salt restriction fails for such a large proportion of hypertensive patients. The problem isn't the salt. The problem is the hormonal environment that prevents the kidneys from responding to it. Insulin resistance compounds this further. When cells become resistant to insulin, the pancreas compensates by producing more of it. Fasting insulin levels can be double or triple the healthy range, even when fasting glucose, and A1C appear normal. Those elevated insulin levels continue locking the kidneys, continue driving sodium retention, continue raising blood pressure, all while standard lab panels show nothing alarming. The intervention that most reliably resets this system is time-restricted eating. By compressing all meals into an 8-hour window and fasting for the remaining 16 hours, baseline insulin levels fall substantially. During the fasting window, the kidneys are unlocked. Sodium is excreted. Blood volume normalizes. Blood pressure drops. Clinical research has shown reductions of 10 to 12 points systolic from this approach alone, sustained over 8 weeks, without any changes in diet composition. Combined with resistance training, which increases the density of insulin receptors in muscle tissue and measurably improves insulin sensitivity, and modest additions like a small amount of apple cider vinegar before meals to blunt post-meal insulin spikes, the effect is compounding. Insulin normalizes. The kidneys regain their regulatory function. Blood pressure adjusts accordingly. Dr. Hargrove followed a patient I'll call Raymond, 68 years old, pre-diabetic, fasting insulin at nearly double the upper limit of normal, blood pressure of 142/88 on 2 medications. 16 weeks after implementing time-restricted eating, resistance training 3 times weekly, and these modest dietary additions, Raymond's fasting insulin had dropped into the normal range. His blood pressure read 118/76. Both medications were discontinued. 2 years later, his numbers remained stable without pharmaceutical support. His kidneys are functioning as they were designed to. These 4 mechanisms, glycocalyx degradation, arterial calcification, nitric oxide depletion, and the insulin kidney retention cycle, are the actual biological architecture of hypertension. They are not the mechanisms that blood pressure medications address. Medications reduce the pressure reading. They do not repair the glycocalyx. They do not reverse calcification. They do not restore nitric oxide enzyme function. They do not lower insulin or unlock the kidneys. They manage the number while the disease continues underneath. That is not acceptable when the tools to address the actual mechanisms exist and are available to any person willing to use them. Restore the glycocalyx by eliminating blood sugar spikes, increasing sulfated polysaccharides from seaweed-derived supplements, and flooding the diet with polyphenol-rich, antioxidant-dense whole foods. Reverse arterial calcification through vitamin K2 to activate the calcium redirecting proteins, vitamin D to guide calcium into bone, and magnesium to prevent new crystal formation. Rebuild nitric oxide capacity through isometric exercise, nasal breathing, and protecting the enzyme systems that make it. Reset insulin through fasting windows, resistance training, and specific dietary strategies that reduce the hormonal lock on the kidneys. These are not theories. They're the biological mechanisms through which arteries heal. And when arteries heal, blood pressure normalizes, not because it's being suppressed by a drug, but because the vessels are doing what healthy vessels do. None of this replaces medical supervision. Work with your physician. Monitor your readings consistently. Reduce medications gradually and only with guidance. But do not accept the idea that lifelong pharmaceutical management is the only option available to you. It is not. The mechanisms that created the problem are reversible. The arteries that have stiffened can become more flexible. The endothelium that has been damaged can regenerate. The kidneys that have been locked can be unlocked. The cardiovascular system is not static. It is constantly remodeling, constantly responding to its environment. Give it the right inputs, the right nutrients, the right movement, the right hormonal conditions, and it will rebuild itself. That is what recovery looks like. Not a number on a monitor held down by medication, but a vessel wall that is genuinely, structurally healthier than it was before. That choice is available to you. And it begins with understanding what hypertension actually is.